Building capacity for antiretroviral delivery in South Africa. A qualitative evaluation of the Pulsa Plus nurse training program. An article by J. Stein, S. Lewin, L. Farrell, and many others. Video and image compilation by Caitlin and narration by Mallory. Let's begin.
The Free State of the Province of South Africa, located at the southernmost point of the continent of Africa, has a high prevalence of HIV infection. In 2008, it was estimated to be more than 5 million people and constituted 31% of the patients who sought medical care. In response to this epidemic, the South African government launched an antiretroviral treatment program in order to combat the spread of tuberculosis and complications with the HIV/AIDS infection. Early on, problems were detected with the implementation of this program, which was the demand far outweighed the ability of primary health practitioners, which, in the form of doctors, to meet the needs of those requiring treatment. The industry responded by increasing the number of healthcare practitioners, this time in the form of nurses, who were able to be responsible for screening and diagnosing patients and assessing those who qualified for the treatment of AIDS patients to hospital doctors for eventual treatment at nurse-run clinics, where it was the nurses, under the provision of a doctor, who were able to issue medication and conduct clinical monitoring. Pulsa Plus, which stands for the Practical Approach to Lung Health in South Africa program, is a health systems-based approach to training for primary care providers. The program has been shown in random control trials to be a promising model for improving quality of care and the control of priority respiratory diseases without extra staff in a resource-poor primary care setting, much like South Africa. Pulsa Plus was developed at the request of the Free State Province following the successful implementation of the original Pulsa program. The plus in Pulsa Plus was added when the program was adapted and reconceptualized to incorporate the management of HIV and AIDS. South Africa has the highest co-infection rate of HIV and tuberculosis in the world, and tuberculosis is the leading cause of death among HIV-infected South Africans. It made sense to combine the lung training program with the new program that was now required by the government. This approach was seen as having the added advantage of protecting against a retroviral program dominance and retaining attention on the management of underdiagnosed and undertreated priority diseases, including those that were HIV related, such as tuberculosis and other illnesses such as asthma. The Pulsa Plus program is based on the principles of educational outreach, which is a strategy that has been shown to be effective in changing private health care provider behavior and practice. Guidelines were evidence-based. They are also tailored to existing national and provincial models of care and designed to be applicable in under-resourced PHC clinical settings. The guidelines were designed to be as simple and self-explanatory as possible. The intervention, nonetheless, involved a training program to facilitate guideline use, given that the impacts of passive guideline dissemination on practice are modest. What this program looked like to the nurses who were participating in it was the provision of short, face-to-face, in-service, in-house, interactive training by a trusted outsider. Using a cascade training approach, nurse trainers were trained in both content and learner-centered group facilitation in order to transfer relevant knowledge and skills to primary health care nurses at a clinic level. Basic counseling principles emphasizing the importance of guiding the client in taking responsibility for all health-related decision-making were also conveyed and practiced in role plays focusing on common clinical encounters. The 15 clinics chosen by the Free State Department of Health to be involved in the first phase of the provincial ART rollout were randomized to receive either the Pulsa Plus guidelines and a 1-week provincial training course only, or to receive the provincial training and the Pulsa Plus guidelines as well as an additional Pulsa Plus training package. The team of professionals who were to train the nurse trainers themselves was a group of 3 medical doctors who specialized in tuberculosis and AIDS care, as well as a facilitator who had extensive expertise in the nursing sector. The 9 nurse trainers who are participating all had varying degrees of medical knowledge and prior nursing training experience. What they did have in common was that these nurses were all employed by the Department of Health as tuberculosis and HIV co-coordinators. The 5-day intensive live-in training course was followed by 3 6-weekly support visits from the core guideline and training development team. Informal individual support contacts with the nurse trainers were also provided. The qualitative evaluation aimed to take a deeper look at the perceptions of the nurses who were in the primary healthcare provider role who were involved in the governmental program, specifically the PULSA Plus program. Qualitative data was collected in 2004 and 2005 using a variety of methods, including unstructured participant observation of the 5-day training program of nurses in the control group, as well as unstructured participant observation of the 5-day PULSA Plus training program and follow-up meetings. This allowed for the systematic comparison of training approaches to understand what the respondents' perception of the value of the training that they had received and their remaining training and support needs. Purposive sampling ensured that clinics chosen for detailed study included both urban and rural sites with varying degrees of human and financial resources. By addressing the question, what value did the PULSA Plus training add, authors of the article hope to shed light on those specific aspects of the PULSA Plus training which may have contributed to the more effective implementation and subsequent use of the treatment guidelines in intervention clinics. Nurses who had been through both programs reported that the benefits of the PULSA Plus program were: it was more interactive and less like an information session. The presentation was administered at a nurse's level, which made it less intimidating, more appropriate, and more relevant to the population of those who work on primary treatment and care. There was value in the way that the instructions and facilitation were integrated into the program, and nurses reported that they liked the more patient-centered approach to the promotion of health behaviors, such as drug adherences. Nurses also liked how the training and practical clinical work were conducted in an ongoing process that allowed for feedback from the nurse trainers. This was seen to increase the usefulness and efficacy of the training. One of the perceived barriers that this program reported was that nurses had difficulty meeting all of the on-site training sessions because of overlapping work commitments. Some nurses expressed preference for a training program that removed them from the stress of the work environment. Nurses reported that emotional support was a need that should be addressed more due to the emotional toll of the work itself and the increasing workload that the nurses face. Nurses said that this ongoing engagement over time provided them with this support. Here's what they had to say.
I went to provincial training before we started PULSA Plus. Yes, it sounded okay, but it was, to me, more superficial. I found when you wanted to ask some questions, you felt you needed a session for us at clinic level. It was a high-quality lecture. It was sort of an information session. And when I went to PULSA Plus, then I felt, now we are being trained.
We had time to go and revise. It was 1 chapter a week, and from one Tuesday to the next Tuesday, you've seen many TB cases. You've actually applied what you learned. So it was actually better, the PULSA Plus.
I felt intimidated at provincial training. When you're a primary care nurse and you come with actual problems at grassroots, and when you pose such questions among high-ranking academics, because we had people from universities and doctors from hospitals lecturing, so now we are talking another language.
The modules from province is like a lecture. How can I give a sick person a lecture? A frustrated, miserable person a lecture? We were going up too high above the patient when it must be done more practically, and the patient should be more involved.